Welcome to this morning's discussion on rehabilitative palliative care workshop. So my name is Josephine Mosset, and I'm very pleased to moderate today's discussion on behalf of Cancer Patients Europe. Before we begin, a few housekeeping points. To ensure a smooth and focused discussion, please note that participants' audio and video functions have been disabled. The chat function will remain open throughout the session, and you're welcome to use it to share comments or questions. We kindly ask you to hold your questions until the dedicated Q&A segment, which will take place after the panel discussion. This will help us keep the agenda on track. During the Q&A session, we will address as many questions as possible. However, due to time constraints, we may not be able to respond to all questions during the webinar. If your question is not addressed, please feel free to contact me or my colleague Kastub Duranda, who will be sharing his email address in the chat, and we will ensure that you receive a response. And finally, we encourage you to actively engage throughout the chat and take your perspective and share your perspective during the discussion. Today's workshop is organized in the framework of the INSPIRE project, with the support of the European Association of Palliative Care and the INSPIRE Consortium. Our objective this morning is to create a patient-centered space for discussion around palliative rehabilitation for people living with advanced or incurable cancer, what it means in practice, what matters most to patients, where the gaps remain, and how patient perspective can more meaningfully shape both services and research. We aim to collect your input and insights ahead of the project's final conference in May. Now, before I go to the first speaker, I think it's important to share a small but very important clarification at the outset. When we speak about palliative rehabilitation today, we are referring to approaches that help people living with advanced or incurable cancer maintain quality of life, comfort, function, independence, and participation in daily life as long as possible. Palliative rehabilitation is not end-of-life care. Instead, here we are going to be focusing on how rehabilitation, particularly physical rehabilitation, can support people in continuing everyday activities, maintaining mobility, and preserving autonomy while living with cancer. For many patients, these aspects of daily life can have a profound difference to well-being and dignity. The INSPIRE project is exploring how rehabilitation services can be better integrated and adapted to support these needs, but research alone cannot answer all of the questions. So to design meaningful solutions, we need to understand what matters most to patients, what works well today, and where important gaps still exist. And this is why today's workshop is centered on patient perspectives and lived experiences. So we will be beginning with a short introduction of the INSPIRE project, followed by some preliminary findings, and then we will move to a moderated panel discussion focused on patients' priorities and experiences. Following this, we will open the floor for an interactive discussion with our participants before closing with a short summary of key messages and next steps. Thank you again for being with us today. We're very much looking forward to the discussion. And with no further ado, please allow me to introduce you to our first speaker, Joan Bailey, Scientific Manager of the INSPIRE project and Postdoctoral Research Fellow at King's College in London. Joan, the floor is yours. Thank you.
Thanks, Josephine, and thanks everybody. It's great to be able to engage with so many people today and people we haven't yet met about the INSPIRE project, and I'm really looking forward to hearing your points and your thoughts as we go through the meeting. So I'm going to start with a little bit about what inspired INSPIRE, and just, I know you're all getting the slides after this meeting. The QR code on this slide will take you to the INSPIRE website where you can read in more depth about the INSPIRE project. But first of all, I want to just take you back, if you can progress to the next slide, please, Matt. As Josephine said, palliative rehabilitation is for supporting people to live well with cancer, and it actually does go all the way through to end of life, but it's not just about end of life. But palliative rehabilitation can support people from being diagnosed with incurable or advanced cancer right through to the end of life, and it's an approach to care that focuses on supporting people to function in roles and activities. We know that after a diagnosis of cancer, many people experience changes and losses in function, in the ability to do the things that matter to them. We know, for instance, that about 1 in 3 adults with cancer require help with personal activities such as washing and preparing food, and about 1 in 2 need help with more difficult activities, more strenuous activities like shopping and getting around. We also know that disability reduces quality of life and leads to hospital admissions. The quote on this slide, which I hope you've had a chance to read while I was talking, is from a participant in one of the studies we conducted while we were developing the INSPIRE intervention. We want to understand how rehabilitation can help people to keep their lives as normal as possible during and following cancer treatments. Now, people may experience changes in function soon after diagnosis, or it might take some time. It might be further after treatment when they experience changes in function. But all along, there will be periods of uncertainty, and people will experience periods of recovery and periods of decline. And this might happen in a cyclical manner, recovery and decline, with many phases before an eventual decline towards end of life. And while functioning sounds very practical or physical, it is about more than physical and practical fit. It's about how well we function in our daily activities, because that affects our identity, our relationships, our social activities, and importantly, our dignity. We also need to consider that people living with advanced cancer vary widely. They may be younger, they might have been previously healthy, and this is the first time they've had a serious illness, or they might be an older adult who's already been living with other chronic health conditions or the changes associated with aging, such as frailty. Rehabilitation services in cancer need to address the priorities of individuals in any life situation. We can go to the next slide, please, Matt. So after developing the intervention and testing it in a feasibility randomized controlled trial in the UK, we worked with partners across the EU to refine the intervention, and the INSPIRE project was born. It's a multinational project evaluating if a new model of short-term palliative rehabilitation improves quality of life and equitable access to care for adults with advanced or incurable cancer. And on this slide, you can see pictures of the team at various stages in the project. So the picture on the top right is when we first started the project. In the long picture in the middle is our first consortium meeting outside the UK. I know we had Leon first, sorry French team. And then our most recent consortium meeting in Denmark. But you can see on the map as well all the partners that are participating in the INSPIRE trial. If you can go to the next slide, please, Matt. But we also wanted to share with you a little bit about how patients have been involved in this project. And I want to say that from the very get-go, this whole project started with a question that a patient asked me when I was working with him in the gym in the hospice that I was working with in Liverpool in the north of England. He wanted to know why he didn't get all the support that he was getting from the rehab team in our hospice when he was first diagnosed, and why he'd had to live so long without the support of rehabilitation members in his cancer and palliative care team. Since then, working with Matthew Maddox on the call today and a team of researchers, we've involved members of citizen involvement groups, or public involvement groups as we call them in the UK, throughout as we developed the intervention and tested it in the feasibility trial. We also captured patients' views in a focus group study during the development work. And citizens were involved during the grant application for the INSPIRE project. And then since then, throughout the research process, from the initial design of the intervention to the start of the trial, citizen members have challenged us to consider issues relating to equitable access to the trial. And they've also contributed important insights on what components the intervention should include, how we approach people to participate in the trial, how we provide information about the intervention, and the design of public-facing information leaflets. Importantly, they've also influenced the language we use to describe the intervention and the trial. For instance, the word fitness. Initially, when we were developing the intervention, we weren't sure if the word fitness was appropriate for people living with incurable disease, and we had comments like, are we raising false hope? But actually, when we discussed it with patient participants in the focus group and our public members groups, they thought it was important. And that although it might not mean the same thing as it does for people who are going to the gym when they're well, for patients in this project, fitness meant fitness to be able to do the things that are important to me, fitness to be able to pick my daughter up from school, fitness to be able to cook dinner. Oncologists wanted us to include the word fitness because they wanted it to mean fitness to be able to receive palliative oncology treatments. So the word fitness has been a very, very important word for us to think about with participants. That's just an example of how public members have contributed to us. We also had a discussion around the words incurable or advanced cancer, because in different countries, those have different meanings. In some of our sites, the word incurable meant that there would be nothing that could be done or no treatment, which of course isn't the case. There are still treatments available for people with incurable and advanced disease, but we had to kind of wrestle with that and make sure that in each setting we were using the right words that would be inclusive for patients and wouldn't make them feel excluded from the trial. During the trial as well, citizens members in the UK have been part of the trial steering committee, which is kind of the oversight and the governance of the trial to make sure that the trial is happening in the right way and is being managed well. And we can go to the next slide, please, Matt. And then from September 23, we trained physios and OTs, in the trial we call them rehab practitioners, at all sites to deliver the intervention. And on this slide, you can see a picture of our intervention manual. But we also developed quite extensive training resources, and we had training meetings. And as you can see on pictures on the slide, some of the training meetings were in person. So the top slide was with the rehab practitioners at 2 sites in Italy, at Reggio d'Emilia and in Milano. And then the bottom slide is training the rehab practitioners in Copenhagen. And in the UK, we also trained people in person, and we had other online meetings with the rehab practitioners in Prague and in Norway and in France. Factors that patients and citizens members had highlighted as being important during the development phase are key features of the intervention. Each participant receives a person-centered and tailored intervention. We use a goal-orientated approach, focusing on what matters to the person. The intervention provides rehab strategies to support people with symptoms that might be causing them distress and impacting on their daily life, with physical activities and fitness, as well as participation in daily activities and family and community life. During the panel discussion, if of interest, I can give you examples of some of the goals participants chose to work on during their rehabilitation. But thank you for listening, and I hope I've been able to give you a little sense of what INSPIRE is, why it matters to patients, and how patients have been involved. So I'll hand over now to Professor Maddox, who will tell you about our preliminary results.
Thank you, Joan. Thank you for this presentation and also the clarifying it goes all the way to end of life care. I think I was being a little over when I was presenting. I just wanted to so that everyone's very clear. We are not just talking about end of
Yes,
life
yes.
care. And also really appreciate the weight of words that you share and this example of what fitness means. I think that's very inspiring and highlights how patients can really shape projects. So as you were saying, please welcome Matthew Maddox, who is going to be presenting the preliminary results. And Matthew is the scientific coordinator of the INSPIRE project and a professor of health services and research and rehab at King's College London. Matthew, floor is yours. Thank you.
Thanks, Josephine. Thank you very much. And thank you everyone for showing your interest in attending this morning or watching a recording of this event in the future. So my name's Matthew. I'm a physiotherapist and I'm a professor of health services research. I work at King's College London and together with Guillaume Economist in Lyon, I have the pleasure of leading the INSPIRE Consortium. Which has really been a wonderful, rich and interesting last 4 years. As we go through the last stages of this project, we're all realizing quite how fun it's been along the way and how much we've learned during the project. And I want to share some of the preliminary results with you this morning from the INSPIRE project. I'll also just make the point that we haven't yet got the main finding of our trial. So lots of these results relate to the topic that we're studying, to the topic of rehabilitation and how that fits in the context of oncology, when people are living with incurable or advanced cancer, and how that relates to the context of palliative care and the last weeks and months and years of life. You can see on the slide here a schematic of our project, and the yellow box in the middle is what we call the main trial. So we've undertaken a large randomized controlled trial where we're comparing usual care to the INSPIRE intervention, which is really a routine offer of rehabilitation. People get to see a physiotherapist or an occupational therapist, and that person will attend to their symptoms and their mobility and their social participation in a very structured but a very personalised way. Either side of the trial, at the start, we have what we call the comparative service analysis and an intervention readiness work package. These pieces of work were to understand how the different services that are taking part in INSPIRE differ, are the same, and contrast with each other. And then the intervention readiness work package 2 is helping us understand how we can structure and package and indeed teach people how to offer this standardized intervention. At the other side of the trial, on the right-hand side, we have different analyses. We have our main clinical and cost analysis, and we expect to report on those in the autumn of this year. We'll close our database at the end of May, and we should have all of the analysis, which is pre-registered, and you can find that on our trial registration pages to be completed in the autumn. And alongside, we've also been gathering evidence around rehabilitation in the context of palliative care, and we're delivering some evidence synthesis for various topics and for this topic overall, and also getting some consensus on issues around perhaps when might this start, how it can be introduced into practice, what are the kind of core and optional components of palliative rehabilitation, what are the outcomes of interest. And we've been publishing throughout our consortium effort, and we'll continue to do so this year and into early of next year. So I want to tell you some findings for most, if not all, of these work packages, and give some idea about the breadth and the depth of learning that's taken place throughout the study. So this is what we would call work package 1, which is the comparative service analysis. And this was brilliantly led by our colleagues in Norway to understand the different landscapes of where we would take place, where the trial would take place. They did a mixed method study, and this consisted of a document analysis looking at regional, national, and international policy documents. They also did some stakeholder interviews, for example, with clinicians who were delivering rehabilitation in the context of palliative care, or people representing patient organisations in the respective countries where INSPIRE was taking place. And finally, they did an online survey with over 200 responses from clinicians, from patients and families, from service managers and service planners in the different health and care systems. So combining those three methods, they had some general understanding that there was very varied and different use of the terminology in this context. People were understanding rehabilitation differently, palliative care differently, and of course, palliative rehabilitation in different ways. So there was some common grounds in these different understandings, but the concept of what palliative rehabilitation is, including how it was used in official documents and how it was used in clinical training, is not yet standardized. And in particular, it's difficult to delineate, to separate palliative rehabilitation from palliative care. And I can really understand that difference and how that might be tricky to tease apart. Because the best palliative care, of course, is holistic, of course, considers the whole patient, including their function. And the best palliative care service would indeed include aspects of rehabilitation, and ideally have professionals who could deliver rehabilitation as part of that care offer. There was currently limited integration into cancer care, and there's definitely what we would term a postcode lottery, depending on your home country, your region, and even your local postcode. Your offer of palliative rehabilitation will be quite different. And it will also differ depending on the type of cancer that you may have been diagnosed with. For work package 2 around the intervention readiness, there was a huge group effort to collate all of the different best practices and all of the different educational and information materials that people would offer as part of their rehabilitation services. And these were placed into what we would call an intervention manual, and a training package was developed. So primarily, this was to help those people who were delivering the rehabilitation within the trial to offer this standard intervention. So we knew what we were testing. But excitingly, we've had some partners from the Czech Republic, from Prague, who have joined our consortium in one of the hop-on schemes they call within the Horizon program. And they've taken this educational package and they've converted it and taken the kind of key elements of this training material to produce an education package, which will become freely available towards the end of our project. So those clinicians who are practicing and offering rehabilitation for people with incurable cancer can get the information which we've collated as a consortium. They can access training to get a more common understanding of what palliative rehabilitation is, and they can get some signposting to some excellent resources and existing educational and qualification packages so that they can improve their clinical practice offer. And we've also shown an excellent kind of peer learning and a group learning dynamic within this INSPIRE Consortium. So each month, people have joined a call online, those people who are delivering the intervention as part of the trial. They've shared stories, they've shared case examples, they've had discussion around different aspects of care. And I think everyone is kind of improved in their kind of network, in their confidence. And we've done this in a trial sense to try and ensure everyone is delivering something standardized, but it may well have subtly elevated the level of care which is being offered. Because with this manner of peer learning, there's been some excellent kind of shared examples, and people who may well have had kind of blind spots or parts of their practice where they're not so confident will be exposed to some expert clinicians from across Europe to develop what they're offering to the next person receiving care. So work package 3, this is the main trial, and this is a graph showing in red the kind of projected recruitment to this trial, and in the black or the dark blue line, the actual recruitment to this trial. So definitely recruitment to the INSPIRE trial was a success story. That means, of course, that there was good organisation and good buy-in from the recruiting clinical sites. All of those sites who joined the study made a huge effort collectively towards this recruitment story. It also reassures us, and I think reassures the public, that there is a need and an interest in rehabilitation trials in this particular population. If rehabilitation didn't fit this population, if it was something which was not so accessible or not so aligned with the needs of this population, there wouldn't be this level of interest, and the recruitment, simply wouldn't have been as we expected or as we hoped for. And alongside the study, there's been some huge communication efforts to help people understand good recruitment practices, how best to support people taking place who are joining the trial to get the best experience possible, so that we can receive the right number of patients to answer our clinical question as best as we can. Throughout the trial, we've also had, led from Denmark, a really exciting effort around what we would call equitable inclusion. So we want to make sure that the trial is not something which is just being offered or just being seen by particular groups in our local communities. We want each person and each part of the community to see that rehabilitation is something which is on offer to them, which is aligned to their particular needs and interests and preferences. And we want each person to feel invited to take part in this study and to be able to make that balanced decision around whether to take part themselves. So we've done that with a very consistent effort throughout the trial. People have undertaken and completed site-specific strategies where, as a group, anyone who's recruiting and part of that local landscape are understanding who's in their population, who are the different people which might be residing in the local area where the trial is recruiting from. Are there different characteristics? Are there different individuals? Are there different groups within that wider community who perhaps need to see things differently? They need different visuals, they need different language, and they need more flexibility to be able to join this trial. A couple of examples might be people who are quite reliant on a working age carer. And for them to get information and to have a discussion about the trial, that must take place in the evenings or over the weekends. If we're using a 9 till 5, Monday to Friday pattern, then that key person who's looking after perhaps their mum or their dad isn't around during that time. And in doing this restricted window of recruitment, we're excluding that person. Of course, there'll be differences in language, differences in kind of social preferences, differences in mobility and finances. And so, in many individual ways, we've committed to understanding how each person might want the trial offered and all of the different ways which we might be able to help that person participate. And we've had lots of successes individually, but we've celebrated each one where, for example, a translator is used to help person join the trial, where there's been visits in a kind of mutually agreed place, be that the clinic in the hospital or their home at a convenient time. So there's lots of good recruitment practices and good learning, which we're sharing in a forthcoming paper. So towards the end, we started to look at some of the processes of our study as we're nearing the end of recruitment. One of the checks we do, and this is very preliminary, is just to see what we anticipated delivering and what each person got in the study and what was delivered. So around 90% of the patients in the trial had at least 2 of the 3 sessions, which was predefined for us as being per protocol delivery, and they received a rehabilitation action plan. The vast majority of people set at least 2 very personal, individualized goals around daily life and around function. And part of our treatment approach is an onward referral to the existing services. And we had referrals to occupational therapy, to dietetics, to group exercise programs in the community, and to psychology. And the key kind of ingredients of our approach in attending to people's symptoms, in helping people remain mobile and physically active, and in helping people stay socially connected and to participate in the social activities that they value the most. Those things have happened for each person, and for most people, they've happened as a trio, and you can see some brief information there. And finally, we want to also develop the future leaders in this field, and we want to grow research capacity in this field. And we had several people who have undertaken their PhDs or registered and are towards the end of their PhDs as part of the INSPIRE programme. They've taken topics from within our broader rehabilitation topic around wasting of muscle, which many people with cancer can experience, around mobility, what that means, how it can be measured, how it can be improved, and around occupational therapy and around exercise and nutrition-based interventions. So there's been a whole breadth of really detailed study from each of these individuals and many more people undertaking master's projects, for example, and their learning has all been shared throughout, and we'll have a great set of graduates from PhD programs as part of the study. So to finish, a lot of this project, irrespective of the main trial finding, has been about building understanding and building capacity in this particular field. And we want to share our understanding and we want to share each of these findings, but of course, also be receptive and engage in the very discussions which we're having today, to try and build this as a specialty so that it can be understood, modeled and packaged. And at that point, it can start to be reimbursed and it can start to be built into health systems. I think until we've got that clarity, irrespective of one particular model and whether that's clinically effective, this kind of specialty of rehabilitation needs to be understood together and through discussion. So I'll stop sharing there. Thank you everyone for your time and attention, and I look forward to everyone's thoughts. Thank you.
Thank you, Maddox. Thank you for brilliant presentation. I have so many thoughts, and I'm really excited for the discussion that will come. Some ideas. Just to recap a bit what you're saying, that I think really interesting is the fact that there is a different understanding of what rehab, what palliative care, what palliative rehab is. So I think this is so timely that we have these discussions. I was writing notes down as you were talking, and the fact that they need to be some equitable inclusion plans as well, because as you were saying, a lot of people that provide care may not be available at the usual times that you would be conducting this work. So I think that's really interesting. And finally, the fact that we need to build understanding and capacity in this field, and this, for that to become a specialty, and that then we have it in our health systems. I think that's brilliant. I think that's really exciting. I think it's really important that we work towards this, because this is such an important and essential part of care. So thank you for this presentation. So I know Joan will be joining the discussion, but of course, Matthew, please feel free to also jump in. The idea for this panel discussion now is to be very organic, very interactive. And so I'm also turning to participants in this meeting. Please prepare some questions, as you will have time to interact during the Q&A session. Now, without any further ado, please let me turn to our first panelist. Our first panelist is Christine Campbell. She is a person living with advanced cancer in Northern Ireland, and has some brilliant experience that she can share with us on what palliative rehab looks like for her. So, Christine, from your personal, I have two questions for you. Please answer them as you want. My first one is, from your personal experience living with advanced cancer in Northern Ireland, what has palliative rehabilitation meant for your daily life? And where do you feel the biggest gaps still are? And I just want to refer also to a discussion we've had in the past about an area that is often overlooked in palliative rehab, which is intimacy and relationships. And so, from your experience, how does palliative rehabilitation support or fail to support patients in maintaining intimacy and identity? So, two quick questions. Please feel free to answer whichever one first. Yeah, thank you very much.
Thank you for the introduction, Josephine. It's lovely to see everybody here this morning. As you've said, I'm Christine Campbell. I have stage 4B high-grade serous ovarian cancer, and I was diagnosed in April 21. Unfortunately, I was given a life-limited prognosis in July 23. Between 21 and now, I've been in and out of palliative care. And palliative care to me is a true partnership with those organisations that actually support me to enable me to live my life the way I do today. And that's through various things. I heard Matt talking about holistic approach. An holistic approach is really important in palliative care, because more and more people now are living with and beyond cancer. There is more research taking place. People's prognosis are living longer. So the role of rehabilitative support in palliative care is going to become more and more important. To me, when I originally got my diagnosis, it was very traumatic. Anyone who receives a cancer diagnosis, it is an extremely traumatic time. There's mentally you're affected, physically you're affected, in that when you're going through treatment, your body changes, in some cases your hair will fall out. If you've had to go through surgery, etc., all your body image changes. And for me, I find that very difficult. I was a very active person before my diagnosis, but during those first year, 18 months, I found it very difficult to be me, Christine. I was the disease, I was cancer. I wasn't just me. And I wanted people to see me as Christine, as a mother, as a partner, as a niece, as an aunt. I wanted people to see me in that perspective, not just as a cancer patient. And that's where palliative care is a real true partnership, because those organisations that I engage with respect to my palliative care, actually treat me as a partner. They listen to my concerns. They listen to what my needs are beyond my treatment setting. And that is so important to me. And it also gives me back a sense of control. When you're in the seat of palliative care, there seems to be a loss of control within your life. But that gave me a sense of control back, because it was a true discussion about what my needs were, whether they were physical, emotional, financial, spiritual, all those things that don't a surgeon doesn't look at, and your oncologist doesn't necessarily look at as well and take into consideration when you're having your treatment. And it's really important to know that you go in and out of palliative care. You don't always stay in palliative care, because that is the whole role of palliative care, is to enable you to carry on living your life. So it's to enable you to improve yourself, whether it's through exercise, through counselling, whatever it happens to be, and that those things can have a really positive impact on how I move forward with the time that I have left with a time limited prognosis. There is a lot of gaps in Northern Ireland in respect of palliative care. We've just recently completed the palliative care inquiry in Northern Ireland, and I spoke both in the Senate chamber on how palliative care impacted me in Northern Ireland and where I felt the gaps were. And I did feel very listened to. And afterwards, when the recommendations for palliative care from the palliative care inquiry came out, one of the recommendations that I put forward, one of the suggestions, has actually been adopted. And hopefully that is going to be driven forward. And that empowers me that people like ourselves, patients, can advocate and can empower other people to actually push for changes that are needed around palliative care. Something that I'm quite passionate about, and pardon the pun, is around sex and intimacy. It's an area that is very much overlooked when people are in palliative care, and especially rehabilitative. As I said, people are living longer after a diagnosis, and you want to build those closer relationships with your partner, to have a healthy relationship with your partner. And I think it's very important that that's an area that we can be more open about, to remove the stigma around that. As somebody said the other day in a WhatsApp group, I'm not dead yet. And I take that on board. I'm not dead yet. I want to continue my life. I want to continue my life to the best of my ability. And if that is building more closeness, more intimacy with my partner, which actually supports my mental health as well as my physical health, then that is something that I really want to advocate for in palliative care. There's very few resources within Northern Ireland to pursue that. And I think it's something that there needs to be more investment in. There needs to be more discussion about. Last week I went to the first ever anal cancer conference, and people were so honest and open about what their needs were, and even their sexual needs, no matter who your partner is, and how that brings them joy in their life, and how that enables them to continue to have a sense of normal. And it is really truly a new sense of normal that you have when you're in palliative care. And as I say, there's times I've dipped in and out of it. But most of the time, I find that it's what's supporting me and making me the person that I am today, to be able to enjoy my life and to carry on living my life to the best of my ability, um, through their guidance, through their support. And I think there needs to be a lot more funding within palliative care settings, no matter what country we're in. It's very much, we do have a number of hospices in Northern Ireland, and people not think of hospice as somewhere you go for end of life, but it's not that. It's somewhere you go to enable you to continue to live your life through their support, their help with your medication, their help with your mobility, etc. Um, and they are very badly funded in Northern Ireland, and I'm assuming that's the same across the rest of Europe. There needs to be bigger investment within that network, that it doesn't all fall down to, there's a certain amount of government funding available for that, but it shouldn't rely really on donations. And especially in these really tough economic times, that someone who's wanting to be in receipt of palliative care to maybe go to a hospice for a few weeks, really they're dependent on funding from the public for that. And it's really important that us as patients are involved in making those policy decisions around palliative care and what the needs are. We are the patient. We are the ones who are facing the day-to-day realities of policymakers' decisions around palliative care. And I think, especially in Northern Ireland, where MLAs, we still don't have a fully funded cancer strategy. And part of that cancer strategy is to implement palliative care, to look at areas of improvement. And unless that strategy is implemented and fully funded, there's going to be no improvement in Northern Ireland at this moment in time. And even when it is funded, you're talking about 5 to 10 years down the line before it would be adequately resourced, as in training required for those who need to carry out palliative care as well.
Thank you, Christine. Thank you for such a powerful intervention. And I first want to start by congratulating you for your political engagement towards this topic and the success you've achieved in Northern Ireland. I think that's extremely inspiring. And it's an example to follow for the patient community across Europe. So really, thank you. I think some of your statements, the fact that rehab is more and more important and it's becoming a part of cancer treatment, I think is really, like, it already is, but it's becoming a more important part. I think it's really powerful. And I also, want to highlight your call for more funding, for more systematic funding. I think this is where this connects really well to what the INSPIRE project is aiming to achieve as well. So just Joan, putting you on the spot here a bit, but I thought, would you be able to, in response to Christine's intervention, where we heard important points about aspects such as intimacy and communication, can you give us a bit of an overview of how these types of needs are currently addressed within INSPIRE?
Hi, yeah, thanks. I think because it's a personalized intervention and the rehab practitioners, when they approach the participants, will ask them, what's most important to them. There's definitely scope within the INSPIRE interventions to address intimacy needs. I think where we might not do so well is whether or not we trained the rehabilitation practitioners well enough in advance to anticipate that. I also think that for my clinical experience would suggest that sometimes patients take their time before they admit all their deeper needs. They want to trust the person first with something maybe easier and see how you respond to that before they will let us know what more deeper and maybe personal needs are. So it may be that one of the limitations of the INSPIRE model is that because we only have 3 contacts, that there isn't time to build up the relationship with participants where they feel they can trust you to share those kinds of needs within this model. And it may be that those needs might be picked up more when we refer people on to ongoing support. But I think it's definitely a point of learning as a team that we can take away from Christine. And this is why, again, patient involvement is so important. That, what did we miss in the INSPIRE intervention? What did we do well, and what could we have done better? And how would we need to implement INSPIRE to ensure that intimacy needs were included in a future rollout? For sure, as a clinician, I can remember managing intimacy needs, supporting people with intimacy needs, but I think it might be an area of the INSPIRE intervention that we could have done better.
Thank you so much, Joan.
Despite it being within the scope. But yeah, thank you.
No, thank you so much. I think excellent. The point of this discussion today is to be able to also, right, identify areas where we can continue to progress. So I think this is excellent. Thank you so much, Christine, for bringing this to the discussion and for, again, such a powerful intervention. Now, let me turn to the second speaker of this panel discussion this morning, which is Catel Maguet. Catel is a researcher and a patient advocate with lived experience of colorectal cancer, and you bring a unique perspective combining personal experience, cross-country healthcare insights, and expertise in patient-reported outcomes. So, Catel, my first question to you this morning is, you experienced cancer at a relatively young age and are very physically active. Can you share your experience of trying to return to physical activity after treatment and what's being considered too fit for rehabilitation revealed about gaps in current supports?
Yes, thank you very much, Josephine, for the introduction. Yes, that has been my challenge. I was too young to be diagnosed with cancer, so I had really several years of misdiagnosis, and I was diagnosed with stage 3 colorectal cancer at 40. In my luck, indeed, like you said, I was very fit and very active, but had some really intense treatment. I went through radiotherapy and chemo, and I was able to remain active during the first treatment, so that was quite good. But then I had to undergo 7 surgeries, and including having a permanent stoma. And for me, that was really the 7 surgeries happened within 2 years' time. So they were very close to each other. So the recovery time between each surgery was not there. And I didn't get any support. And that was so difficult. I think I saw a physio twice when I was in hospital. And the idea was that they would teach me how to get out of bed, which of course is, it seems stupid, but it's when you've got a stoma, it's almost impossible to get out of bed if you don't have the right technique. And so it's very important to learn how to twist on your side and get up without damaging more your abdominal wall. But then they kind of scare me so much, like I was not allowed to lift anything for several months. I was not able really to do anything. And sport is really my way of coping with stress. It's also an activity that I do with my partner. And that's a way, sport has always been in my life. And I was an Olympic weightlifter at the national level in France. And I've got also my coaching diploma. So I really thought that I knew everything about going back to the gym. But then I couldn't. I really didn't know where to start. I was really scared of getting a hernia because, of course, with a stoma, you had higher risk. And when I asked at my hospital, I didn't get any support because I was too fit. They've got a rehabilitation department, but with very limited spots. And I was definitely not admitted because I was too fit, too young. And so they gave me a few physiotherapists in my city. But when I was there, the level was really not what I was expecting. And finally, I had to reach out to the stoma patient organization. And they went through, they contacted several people. And finally, after 1 year, I found the right physio. But that was 1 year after my last surgery. So it's almost 3 years without the right physiotherapist. And at that time, also, it was very difficult for me mentally to cope because I was not allowed to do anything. I was at home. I couldn't work. I couldn't travel. And also, when it comes to mental support, there was such a long waiting list. I had to wait also 1 year to get access to a psychologist at the hospital. So it has been very difficult because it's really difficult to hear that you are too fit, even if I was at my lowest, fittest level. And of course, my idea was not to go back to weightlifting, but it was just to enjoy going back to the gym, doing activities with my partner, going back hiking. And it was so difficult. And I think also, as you said, my background is also in proms. I worked for 15 years in quantitative research, working on unmet needs. And I had to complete several proms. And the first time I did it, I was just, I think, 1 week or two after my first surgery. And I was so frustrated because I felt like I was really at my worst. I think the first surgery was a major one. It was a 8-hour surgery. The recovery time plan was 1 year, so it was pretty heavy. But when I answered the prompts, it was like I scored the highest. Like I could wash myself. I could do everything myself, so I didn't need help. And that's where really like exactly what Joe said before. There was nothing about what matters to me, about traveling, about being able to go out with my friends and go back to work. At that time, I really didn't have any perspective on if I should be able to go back to work even part-time at any point. And I think when you are a young patient, you don't fit in any. You are too young, too fit, but still you are diagnosed with cancer, and it's very difficult to find the right place and to also to get the right information. And I'm French, as you can hear, but I live in the Netherlands, and the system is very different. And it has been quite challenging also for me to navigate the Dutch system. You really need to push far more. You really need to get to know where you can get the right help. So it took me like 4 years or so to have access to a special department for early onset colorectal cancer patients. But for me, it's almost too late. And I'm like, it's only in Amsterdam, so it's only in one of the cancer research center. And I'm like, why? I think it was also Joe said, like, why is it only now? I mean, 4 years later, it's too late. I should have had access earlier, or at least I wish I would have known earlier. So that's also where I'm trying to do, to communicate also to other young patients and also to other clinicians. It's available, it's not everywhere, but it is there. So we need to make sure that younger patients have access to the care they deserve. So that's for me also quite important. And also, when it comes to exercising, we know, of course, that it has a benefit for patients, but what is offered is quite often not at the level of fitness that younger patients are expecting. And 3 weeks ago, we had a speed skating challenge in the Netherlands. We were raising funds for colorectal cancer research, and we were several young colorectal cancer patients on the ice. And I know that several ones are stage 4, so it's incurable, but they were on the ice and they were enjoying it. And it's a sport. Speed skating is a Dutch national sport, so it's very common. But I don't think you will ever find it in a Dutch proms like, oh, are you able to enjoy your speed skating weekly session? No, but why not? And I really think that it's where the prompts need to be much more personalized or adjusted to also different age group or fitness level and to what matters to patients.
Thank you so much, Keter. I think that was also a really powerful presentation. And I also want to thank you for your engagement. Also, you're so very active and you're such a strong advocate for better inclusion of patients that are younger, that are too fit, that don't fit the usual image that we have, right? I think that's really important. And I also really like your points on prompt and the fact that we desperately need more personalization. I think that's really the key message here. And on this specific point, I'd like to turn again back to Joan about what you just said about whether the INSPIRE project approaches personalization in palliative rehabilitation and how the individual patient goals are taken into account. Does INSPIRE include speed skating, essentially?
Not specifically speed skating, but it does include goals. And so
Perfect.
if Cattell had been in the trial and that had been her main goal to get back to speed skating, that would have been one of her measures, and we would have measured it as a goal to attain. And the outcome would have been that she'd attained the goal. The outcome wouldn't have, and so and we could have assessed whether she was making progress towards the goal. We could have assessed whether she achieved the goal, made a little more progress than expected, or a lot more progress than expected, or whether actually things had got harder. So I think, and we're using goal attainment scaling in quite an unusual way, because we're measuring it in the intervention group and in the control group who are not getting into the intervention. And so that's going to be another learning thing for us in the INSPIRE trial, and in understanding how we can measure more personalized goals like this, because one measure doesn't necessarily capture everybody's needs. And it's why objective physical performance measures are very difficult, because somebody can improve their mobility around their home by getting stronger, or they can improve their mobility around the home by using a walking aid. And they're quite different, conceptually very different improvements, and having one measure that can capture both of those things is quite challenging. I also want to pick up on what Cattell said about having rehabilitation services available to meet everybody's needs. And I think this is a really important factor. And again, I think what there's a strength of INSPIRE is, if the INSPIRE model is introduced, we can identify people's rehab needs early and quickly, and we can address things that are quick wins within 3 sessions. But a key factor that INSPIRE relies on is being able to refer people on to the other services they need. And if those services aren't available, so in Christine's case, if there aren't specialist sexual support services available, or in Cattell's case, if there aren't cancer exercise specialists who can support people to exercise to a high level with a cancer diagnosis and the consequences of their treatments, then the INSPIRE intervention will be limited. And I think that's something that we may see in the trial across the sites, and the availability of services to support people after they've completed the INSPIRE intervention. I know in the UK we have some cancer centres which have excellent exercise support, and who would have been able to support Cattell. And I think we have large areas of the country where there would be very little. I also want to suggest that this doesn't always have to be within health services, that there are other providers across the wider healthcare economy that can meet needs. And so there's a group of physios and exercise physiologists and sports scientists who are trying to improve the training of exercise instructor in local exercise facilities to understand how to support people to exercise with diseases, including cancer. And they're being trained to support people to exercise and safety issues and how to progress exercise. So I think the INSPIRE intervention would be strengthened if people following an INSPIRE intervention were able to be referred on to a local exercise facility, so they weren't necessarily having to stay within the health setting to achieve their goals. So that's a quick summary of a few issues. I hope that's helpful.
Thanks, Joan. I think that's very helpful, and I think it's inspiring. So maybe let me turn to another speaker, and I want to bring in Dave into the discussion here. Dave, you are a patient advocate. You are a patient with lived experience of digestive cancer, and you are also very active on a patient advocacy level. You're the chair of the board of Digestive Cancer Europe, so you have very strong and wide perspective. Here I really want to bring you in on the topic of coordination of care. This is something that you've highlighted in exchanges with us, and this particularly for older patients. And in the context of palliative rehabilitation, what, according to you, is currently missing in terms of coordination after and during cancer treatment? And yeah, I think that if you can bring this in, and also I'm very interested in hearing from you, how patients experience palliative services very differently on where they live. And I think this is something that's already been brought in by Cattell and also mentioned by Joan, the fact that there are differences and barriers depending on where you live in getting the support that you need.
Thank you, Josephine, and well done, Christine and Patel. They were very, very good talks, and there's a lot of things I picked up from that as well, especially on the barrier side. It's fitness is personal. It's so personal to each person that it has to be tailored to that person rather than a one catch all. And with Christine, it's also we're not often not seen as the person. We're seen as a patient with a disease, but we are a patient with personal needs, physical needs, emotional needs, and intimacy needs as well. So it's a big thing that we're seen as that person rather than just a patient. Matthew also mentioned the postcode lottery on getting treatment, getting rehab, getting support, getting fitness, everything else. It's so important to understand that we need to join up all the dots. It's so varied from country to country, region to region, city to rural. It's just not all joined up. It needs to be joined up. There's no clear pathway for many of rehabilitation. And we've been talking about fitness, getting rehabilitation. We haven't touched on the nutrition needed as well. And that is so important to be mixed in with everything that we do. It's getting that nutrition right to be able to get that fit, get that fitness back. There are limits on funding across different countries, different areas, staffing. A lot of the services are fragmented. They're not joined up. We don't know sometimes what the hospital 5 miles down the road is doing. So it's important that we join everything. It's lack of clear pathways. We haven't got those clear pathways of what is really needed. We think we know what's needed, but we don't always talk to the patients and their own personal needs. Low awareness and understanding, both by the healthcare professionals and by the patients themselves, of what they can, what they need, and what is available to them. And it doesn't always work that we put it out, in a leaflet, in a patient pack when they get diagnosis. It needs more than that. It needs follow up. It needs to be able to talk and work with people. There's so much going on out there. Coordination after treatment is sometimes left to the one CNS within the clinical nurse specialist in that medical team, and it's not always part of the whole team. We do need that nutritionist, that dietitian in there as well, physiotherapists, and see what is available outside locally. What gyms there are that they can go and get a discount on because they are a cancer patient. It's finding out. It is making sure that we do define what they need and how they need it, and where they go, where they can go to get it. We talked about the emotional support. That is so important, as well as the mental well-being. It's always been living with and beyond cancer in palliative care. We've now starting to add that live well as well. It's so important that people live well. They have that feeling of well-being. They have that feeling of just being able to cope with the day-to-day life they want to live. I know it's not always possible, but often it's just something. A goal can be just that, just living well with cancer and doing an everyday goal. Just walking down the shops, going out for a pub, going out for a meal, going out for a drink. A lot of digestive cancers, especially esophageal cancer patients, can't do that because they can't eat well, they can't drink well. It's a big thing to understand all that person needs. it's so hard not to say patient, but it's what the person needs, and I think that is so important. Is there anything else you want me to add to that, or have I?
No, thank you, David. I think what you were saying was excellent, super powerful. And I thank you so much also for bringing in the aspect of nutrition. It is a topic that we are separately very active on at Cancer Patients Europe. And I think it's such an important part of the discussion. I'm seeing the clock turning, so I will turn to Kathy, but Joan, I will bring you in to close off the discussion before we have a Q&A session. And I already want to thank those of you in the chat that are asking questions. This is great. So, Kathy, can I bring you into the discussion? So, you bring a research and policy perspective as research project manager at the European Association of Palliative Care. And you actually have a background as a dietitian. So, I think this is an excellent segue into your question. So, Kathy, from your experience in your organization, how is palliative rehabilitation being developed across Europe? And how can collaboration between researchers, clinicians, and patients be strengthened? So I think that this is great as a question also to kind of tie in all the points that speakers have been bringing in. So please.
Thank you so much. And it's been a really, really interesting session. And again, thank you to all of those who have shared, Dave, Christine, Cattell. I think one thing I really want to stress at the outset is it's so clear that we should not and cannot underestimate the power of patient voices. So it really does ensure that the future discussions that we're going to have around palliative rehabilitation are really grounded in what people actually value, what they actually need, and what they experience. So your insights really help us to make much more effective, equitable, and implementable changes, whilst also upholding the dignity and the autonomy. And definitely, it's clear that when health services and researchers and policymakers and professional and patient-facing organisations really work to embed patient perspectives, the result should be care which is much more humane, much more impactful, and much more aligned to real-world living. So I work for the European Association for Palliative Care. We're a membership organisation of professionals who are committed to supporting the promotion and development of palliative care throughout Europe and beyond. Our members are united by our vision, which is to aspire to see palliative care availability and accessibility wherever and whenever it is needed, and that includes rehabilitation and palliative care. And we specifically have a task force. So this is formed by members of our organisation, and this includes physiotherapists, occupational therapists, speech and language therapists, dietitians, nurses, doctors, psychologists, social workers, all really looking to see how we can embed a more rehabilitative approach to palliative care and identify and address the barriers and the facilitators to the integration and the adoption of better rehabilitation and palliative care into practice. And I think we can see that the whole concept of rehabilitation and palliative care is moving from something that was really very little known or very little talked about even a few years ago to being a much more organised and a much more widely considered part of care. And that's shaped both by international research, like the research that we're doing with INSPIRE and EAPC. We are a partner in that project. And whilst also the move to earlier support living, or for people living with any kind of long-term illness, as an essential component of universal health coverage. So a recognition that it's not just enough to treat an illness, you need to work towards patient-centered, person-centered care delivery, and really focusing more on what can the services provide to what is actually needed based on what matters most for individuals. But we can see, and it's clearly demonstrated by everything we've talked about today, that progress is not the same everywhere, that there are differences in how rehabilitation in palliative care is even understood, the availability of professionals, the access to services. and that some people will benefit more than others, just as was mentioned, that postcode lottery. So we do need much better and closer collaboration between the professionals, more involvement with the patients in designing services, better ways of measuring impact. And again, it's not just, sometimes not everything that can be measured really delivers the kind of information that you need in order to make services better. So we need not just numbers, we need, as I say, the patient voice, we need the stories as well, because they can really help to help us discover what it is that really makes a difference in people's lives. And I think maybe for the point of view of time, I'll leave it at that.
No, thank you so much, Katia. I think that, as you say, I come from a patient organization perspective, but I do agree. We cannot underestimate the power of patients, right? And just thinking also of Christine and what she's achieved on a political level, I think that's so very true. So I just want to bring Joan back in quickly before we turn to the Q&A. Joan, if you want to react to anything that Dave has said, that Katie has said also, and I just wanted also to Katie to thank you for the work that your organization does. I think this is also excellent and really powerful in making palliative rehabilitation just a essential component of care. Joan, if you want to jump in as well.
Actually, I mean, I'll link particularly through to the INSPIRE intervention and how, yes, we do consider nutrition. We specifically pay attention to that. All the rehab practitioners, when they're doing their assessments, are kind of asked to screen for certain needs. And we are collecting data on whether or not nutritional needs have been identified and whether people are already known to a dietitian. And it's certainly, as Matt said, it's one of the areas where we have referred people onto. I think it's difficult for any one health professional to have all the skills needed. I think there's a quote from an old palliative care textbook that talks about the myriad needs of a person exceeding the capabilities of any one caregiver. And we know that the most effective palliative care is multi-professional, and that's for certain, because different professionals will have a different manner with patients. They'll have different abilities to pick on cues and framing questions, but certainly nutritional needs, as intimacy needs, as exercise needs. A team needs to be able to pick up on when these things are important, and it has been an important feature of the INSPIRE intervention to make sure people are referred on for the right care for their nutritional needs. And I think organising and understanding the role of rehabilitation in palliative care is going to take a lot more work than the INSPIRE trial. But I hope that we can, the evidence that we've got and the learning that Matt explored earlier in his talk, that we can, continue after this webinar and through the EAPC and the other organisations who are working in palliative care to kind of extend the learning from patient experiences, from trials like INSPIRE, and from other studies that are working in this field. I'd like to get some questions.
Thanks, Joan. And agreed. If this can be a step in the right direction, then we're doing it right. Thank you. So I actually am going to turn to the questions in the Q&A. And the first question I would like to ask, and those of you in the panel who would like to answer, please feel free to jump in. So Metka is coming in from the Association Europa Colon Slovenia for Digestive Cancer, where they provide support to patients and family. Currently, their focus is mainly on psychosocial and nutritional support, while it is more challenging to find professionals with practical experience in the field of physical rehabilitation. When it comes to palliative care, they observe a significant level of stigma. As soon as patients hear the word palliative, they often do not hear terms like early palliative care. Instead, they immediately associate it with death and may disengage, despite efforts through lectures, discussions, and articles in their newsletter, including dedicated section of palliative care. And her question is, how can we better communicate to patients and their family that palliative care is not only about end of life, but also improving quality of life much earlier in the course of the disease? So here, please feel free to jump in if you would like to provide some thoughts on this. So let's you among the speakers. I don't know if Joan, there's anything you spontaneously would like to say, or Dave, Ketzel, Christine, please, and of course Katie, if you want to jump in. Christine, I see your hands raised. Oh, Christine, I see that you are still muted.
Oh, after all these years, still muted.
Yes.
I think it's really important that there is communication around what palliative care is. I often speak to people, they automatically assume end of life. They don't. As soon as they hear the word palliative, they just hear blah, blah, blah. They don't hear anything else that you say to them afterwards. So I think there really needs to be a huge communication piece, and all of us as advocates, but even all of us within the healthcare community, have a role to play in educating people what palliative care actually is. Dave, myself, Cattell, we're all in receipt of palliative care. We're here talking today. We're living our lives as best to our ability, with support of palliative care. So it's really important that we emphasize it is the living part. It's not the dying part. And I think as a society, we continually push for to live as long as possible. That as a society and a community, we've actually forgotten that death is a natural part and process of life. So it's about living well with the time that we have left and educating, educating what palliative care actually is. In Northern Ireland, I'm working on a project at the moment, and it's a single point of access. It's not specifically for cancer patients, it's for patients who have been given a life limited prognosis. And what I'm part of the evaluation panel of that, and what it is doing is a doctor, an oncologist, healthcare professional can signpost that particular person to the single point of access, and they then can coordinate with them by working with the patient about what their needs are going forward to enable them to live their life. And I think that's something that's very important and hopefully will be rolled out across the rest of Northern Ireland.
Thank you, Christine. And I think, you said it 3 times. I'll say it a fourth, educating, right? That's our job. We need to do it. And I'm glad that we have the opportunity this morning to do it and that we also take it forward in the future. Dave, I see your hand is raised. Please feel free to jump in as well.
Exactly the same as Christine. It's education. We have all the awareness out there about cancer, about prevention of cancer, about the symptoms of cancer, but we haven't got anything out there for the public about palliative care, survivorship, or anything like that before their patients. And that, I think, is something. It's an initiative maybe we should start somehow. Making sure that people are aware. It is the education, and
Yes.
you can say that all the time, every time, but it's actually putting it in place. Where can we put it in place? How can we put it in place? It's when a person is diagnosed with cancer, they need to be aware of what palliative care is before they're diagnosed, rather than when they are diagnosed. And I think it's just something we just need to do. It's just educate, educate, educate. And it's not just the public, it's also the healthcare to explain it well enough to the patients. Because that is so important that we hear from the healthcare, it's palliative care, but it's not end of life. That difference has to be made. And again, it's going back to making sure you're talking to that person, not as a patient, but as a person. Thank you.
Thank you, Dave. And I think that's extremely also powerful. Yet again, it is true. And, I will confess to myself up until potentially 2 years ago, I think that time I also associated palliative care with end of life care. And I think that, as you say, we all have a responsibility in this call to also educate people around us and also do it before a diagnosis, right? So I completely agree with that. Ketel, please, if you want to
Yeah,
jump in.
also, um, I think it's also for me, how can we break the taboo? Because cancer remains a taboo. And when you are with incurable cancer, it's even worse. So how can we make sure that the discussion are easier, that patients can talk more openly about it if they want to? And because if we don't talk about it, no one is gonna. And I think that's also where there are 2 points. Science has evolved so much the past 10, 20 years. So indeed, receiving a cancer diagnosis doesn't mean that you're going to die anymore. So there are really some improvements. So that's really the first thing. And I think also, well, when I was diagnosed at 40, I didn't know anything about cancer at all, especially not about digestive cancers, because it's such a taboo. And I think I share my experience today because I think that it should be like breast cancer, that we should be able to talk about it openly. I mean, when I said that I had cancer, the first response I get is, "Oh, you had breast cancer." And no, I don't have breast cancer. So I think it's also where it's to free, to open the discussion and to make it easier for people to talk about it. Because then we can educate people. Because if it's still a taboo, it's so difficult to have those discussions.
I completely agree. I think it's essential that we do this and break this taboo, as you say. Katy?
Yeah, I think it's really interesting, and I'm showing my age here when I say that a little over 30 years ago, I remember a conversation happening in Northern Ireland when the new cancer centre was being built and about it being called the cancer centre, and that caused great upset at the time about putting the word cancer on a building because of the upset that it would cause people. And I think we're kind of there at the moment when it comes to the word palliative care. So it's a word that's not accepted. But rather than shying away from the word, what we actually need to do is move towards it and embrace it. And actually, as everyone has said, make people understand actually what it is and what it isn't. And it isn't about it isn't just about end of life, and it isn't just about what happens when the treatment that you receive for cancer is no longer effective. It is something that is complementary to cancer services. It's something that can really improve someone's quality of life. It's not a focus on the cancer itself, it's a focus on the person. And as an organisation, the EAPC a couple of years ago started a European Palliative Care Awareness Day. So it's still growing legs. It happens in May of each year. So that is very much a public facing event to try and raise awareness of palliative care. And there's also some really good local things that happen. And I know certainly I also live in Northern Ireland, so I know very well the work, for instance, that the All Ireland Institute of Hospice and Palliative Care have done for many, many years at a public level to raise awareness of palliative care. So it is happening. It's just a bit like cancer was 30 years ago. We just need to really help with, again, education, spreading the word, dispelling the myths, and really hopefully getting to the point where people actually could benefit from the services. Not only are they made aware of them, but they know of them beforehand and know what is available and appropriate, and are able to ask for the services as well as being offered them. So that will be the ultimate when palliative care really becomes embedded in services.
Thanks, Katy. And I will leave a final intervention to Joan before closing off this webinar. Joan,
Yeah,
please.
I think all these comments have been so valuable. I think we underestimate the power of visual signifiers as well. I know that in our hospice in Liverpool, when people were finally persuaded to come to the hospital, when they saw a gym in the hospice, they were so surprised. I think a lot of the materials that we produce around palliative care often focus on end of life care images because we want to try and open people's pockets to donate to services. But actually we need to show more images associated with palliative care about living, have people accessing palliative care who are hiking, going for a restaurant for a nice meal with their loved ones. I think those kind of visual signifiers can play a really important role. But mostly I just wanted to finish by saying thank you to everybody for coming and engaging with the project. And I hope that we continue to hear from you and you continue to challenge us with what we need to do. And particularly look at our results and share our results when we are able to publish them later on in the year. But I just want to say a big thank you to everybody for coming, and particularly to Catal and to Christine and to Dave for sharing your stories, which, you know, make it more important that we carry on with this work, and that hopefully INSPIRE will stimulate other research projects as well in areas where we have raised questions where we haven't been able to answer. So thanks everybody, and thank you to Josephine and CP for hosting the webinar for us.
Thank you, John, and it was a great pleasure. I can already say on a personal basis that I really enjoyed this discussion. I learned a lot and definitely a lot of food for thoughts. So just to close off this webinar and to not take up too much of your time, so this webinar was recorded. It will be publicly available on our YouTube channel. For those of you who have not had a chance to ask a question or are still formulating a question, please be aware that there will be a QR code that will be shared in the reports to ask more questions. So you will be, and it's actually there as well. So you can already scan this QR code if you want to ask any questions, and we will follow up with the speakers, with the INSPIRE Consortium, so that you do have an answer. So as I was saying, there will be a report. The recording will be made available shortly, and this discussion will feed into the final conference of the INSPIRE project that will take place in May. And of course, as we said, this is a step in the right direction. A lot of work remains to be done, but this is such an excellent initiative, bringing palliative rehabilitation to the level that it needs to be. Thank you all. Thank you for your very kind words. I saw a lot of congratulations and very inspiring messages in the chat. And I also want to thank all of you who have provided a message. I think this is very inspiring to us. And with no further ado, thank you very much. Happy Monday, happy week. And I hope you have an excellent end of your day. Thank you.